My great pleasure to introduce my friend Paul Harris, who is at Vanderbilt University. He's a professor of biomedical informatics and biomedical engineering there, and has about 20 years of experience in clinical research informatics. He earned his doctorate degree in biomedical engineering at Vanderbilt and now is there as the director of Vanderbilt's Office of Research Informatics. He designed and created RedCap, which I think is probably what he's best known for. This is a research data capture system, clinical trials data management system that is free for use. And it's now being used in, 25 academic institutions, academic and nonprofit institutions in 108 countries worldwide. He also created a national program for patient recruitment called Research Match, which is allowing individual institutions to recruit volunteers that can then serve in national research studies. And currently they have 115,000 volunteers and 4,800 researchers across 138 academic institutions. So a huge impact nationwide and worldwide in clinical research informatics. He has interests in novel strategies for data collection, analysis, and dissemination, participant recruitment, engagement and return of value, and software collaboration and dissemination. He currently serves as a PI for the NIH NCATS Recruitment Innovation Center, or RIC. He's the co-PI for the Corey Mid-South CDRN, informatics lead for Vanderbilt's Clinical and Translational Science Award Program, technical leader for the Vanderbilt Verily Broad Precision Medicine Initiative programs. I don't know how he found time to come down here to visit us, but we're very glad that he did.
Thanks so much, Jim. And thanks for the opportunity to be here. I'm going to basically tell a number of stories today, and you know, my task was to think about implementation and innovation. And you'll find soon that I don't stick to my own script even when I'm speaking, and so I've found that a lot of bullet points just don't work for me. So I end up telling stories. So I'm going to go ahead and tell you that I'm going to tell a number of stories around projects that we've developed, the lessons learned from those studies, from those projects to that I think really apply to any project or program that you might build. I should say up front as a disclaimer that after each of these stories, I'll kind of highlight some lessons learned. I could just as easily have pulled a number of projects that were complete failures because I violated these principles, but I chose the successful ones because that was more fun for me. If we have time, I want to talk about a few passion projects that we've got going on right now that I think may be of interest and I hope may be of interest because we're always looking for collaborators and new things. So my mom's slide is not nearly as fun as Adrian's slide, but my mom about every 6 months, I don't know if your moms are like this too, but my mom about every 6 months, I'll be talking with her and she'll say, "What is it that you do again?" Because she doesn't understand this word. What's that? Yeah, right. So you know, my mom, she doesn't want to understand the word informatics, and you know, she doesn't care about all of that, but you know, I think, you know, this usually comes after maybe she's talking to one of her friends and she's saying, you know, I know you work at Vanderbilt over there, but what do you do again? So I explained to her again, you know, here's the deal. You know, I get to wake up every morning, look across Vanderbilt's research enterprise and look for ways that, you know, in a disease neutral way, if we could build tools and methods that would help any type of research, then that's kind of fair game for what we do in the Office of Research Informatics. She rolls her eyes at me and then she asks me again in 6 months because it's not terribly exciting to her, but it really is an exciting space. In 2007, we looked across Vanderbilt's enterprise and said that, you know, we've been in the clinical informatics domain for a long time, and there's a lot to be gained there. But in terms of the last mile, how this is impacting our research enterprise, we really have some gaps. And so we started this office. These are more or less the things that we think about every day and so forth. This, I want to give credit to Duke, since Adrian's here, that I stole this part of the slide from Duke. And it's basically to remind me that, you know, research goes all the way from well before bench to well outside of bedside and then back and forth. So the first story is about RedCap. RedCap stands for Research Electronic Data Capture, and really it was born back in 2004. In 2004, there were a lot of things going on in the world. The one thing that really was bothering me at Vanderbilt was HIPAA. Not HIPAA privacy, but HIPAA security. And I knew, because I'd been working with researchers for many years and building one-off databases, if you will, to store information about prospective studies. I knew when I was sitting down one day filling out a HIPAA security questionnaire around one of our systems at Vanderbilt. I think it was a core laboratory system, and I was answering these 36 questions on this blue sheet of paper. It's so fresh in my mind even that I thought, how ridiculous is it that I'm answering these 36 questions about this system at Vanderbilt when I know for a fact that people are emailing data sets around. They're collecting information on these multi-million-dollar studies sometimes in FileMaker Pro. Or pick a platform, and I love all of those platforms, but they don't, this HIPAA security stuff is not going to be satisfied with the way we're doing business now. My hypothesis at the time was that researchers weren't out there using FileMaker Pro or SurveyMonkey or what have you, because they just wanted to sort of snub their nose at best practices of data security. They were doing it because they were really smart. They had important projects that needed to be done, and we weren't giving them the tools to basically take this back to a centralized approach where HIPAA security and other important features were sort of baked in. So we kind of came up with this idea that if we could figure out a way to deliver those tools, if we can make it easier to do the right thing than the wrong thing, then the researchers would sort of come on board. Problem was we had many projects and we had few programmers, and we didn't want to really have 1,000 programmers working on 1,000 or 2,000 research projects. So we came up with this idea that if we can figure out a way to get the data about the data or metadata for a project into a table, a structured database table, and then maybe we could build one app. And that app could morph for every study depending on the data about the data. So we set about doing that. That allowed us to sort of hit some really easy but useful core features early on that I'll tell you about in a second. And then we launched that first RedCap project in 2004. The way that we launched that project and about the next 50 projects at Vanderbilt looked something like this. There'd be somebody that had maybe heard about it or somebody that hadn't heard about it, and they're looking for support for a research project. And they said, hey, Paul, how can you help us build some sort of data management platform for this particular project? And I would say, no, but let's meet about that. Let me talk about this new thing that we've got going on. It's web-based. It's really easy to configure. It's really free, it's free for you to use. You don't know it and you don't care about it, but it's HIPAA compliant, and that's going to help with your IRB and your grants and so forth. And it's super fast. You can have one of these tomorrow. So would you like one of these? I swear I must have given this talk 100 times, and I would spend the first 45 minutes basically saying that and showing them some modules. And then I would say, do you want this for your study? And remember, it's free. And every one of them would say, yeah, we can't wait to have that. Part of that was, showing them that, the first piece of this is getting good quality data in. So your research coordinators are going to love the fact that it is web-based. You can share it with your colleagues and partners, et cetera. And it's human readable. It sort of looks more like something that you'd want to interact with on the computer rather than something that is a spreadsheet, if you will. So it does all of that stuff right. The next question was literally, Paul, what if you get hit by a bus? So if you get hit by a bus and we've kind of converted out of our FileMaker Pro, what are we going to do then? Well, we better make an export module for you. And while we're building an export module, why don't we make that friendly so that you can get it out, because we know the metadata and we know the data, and we know from here that we're collecting everything in the right way, that we're getting all that validation right. We can not only get the export right, but we can spit out the data about the data in a way that SAS understands your data set or Stata or what have you. And we've been doing a lot on other projects. We've been doing a lot of work on de-identifying EHR records at the time. So we put some of that feature set into the export module. So really just with those couple of modules and and all of the audit trail stuff. That was kind of the base package of REDCap in the early days. So the answer was always, yeah, we want this. We can't wait to get this for our study, and this is what we'll do. We'll send over our, we'll get our coordinator to send over the data requirements. And that's the point where I would say, nope, that's not the way we're going to do this, because you guys know your study a lot more than, you know a lot more about autism or Parkinson's or whatever you're studying than I do. And you don't want me stopping to try to, or hiring people to sort of translate that into this model. Better yet, if we could teach your team how to do that. If it's really, really easy, then it's iterative. You control your own destiny. You have the power to do this, and I can go on and create that next module that you're asking about. So that was really the big sales pitch, right? That was the part that took that last 15 minutes. And I would send them home with a recipe and say, if you'll do this, I promise, within 24 hours, you'll have one of these up and running, and you'll get excited about it, and you'll want to continue on. So that's really how the early days of it went. One of the things that we found was that once this started, especially since we were sort of handpicking some of those folks early on that were from big research labs, we found that if you get somebody that's in a big research lab and they start using your tool, then everybody else is going to be starting to use the tool pretty soon too. So by the end of that year, I think it was August of 2004, we started with Project 1. By December, we were at about 20 projects that were running in this new REDCap platform, which sounds pretty modest now. But if you were used to building these one at a time, well, that was a pretty significant number of folks using it. Just at the end of that year, we did this survey. This was kind of a funny thing, but I just wanted to know, is it working well? How hard is that metadata creation process? What should we change? It was mostly a QI project, but I stuck this one question in about, did it improve your science? And it was funny because we got a bunch of good input, really critical input. People weren't just saying, we love it, thanks for doing it. It was really good input, but every single person said it improved the science. Now, in reality, it's not the widgets, it's not the on-screen stuff that improved the science. It was the empowerment, right? It was that ability to change your mind tomorrow, to basically get everything right, share it with your statistician or your coordinator or whoever was collecting the data. And they have time before the study starts to basically change things, because we're not having to go through a programmer each time. But it was really cool, and I kind of take pride in that, even though my mom might not know it, that by empowering these really smart folks with infrastructure, we're hopefully improving health. Something else that happened just about every time in one of these, in these exercises, these sales pitches early on, was that somebody would say, this is great, Paul, but will it do X? And sometimes the answer was, yeah, it'll do X, just give me about 5 more minutes and I'll come around to that. But usually it was, no, it won't do X, but I heard about that last week too. So that sort of this principle of used systems get better, absolutely rings true, as long as you listen to the end user. Usually that's the sort of thing that would make it into the next module, so no, but wait till next month and I bet it will. The tricky thing about that, though, as a systems builder, is keeping everything, building in complexity, and but making it simple. Because basically REDCap now has many modules. If you need to randomize your patients, it'll do that. If you need to do patient-reported outcomes and do surveys at crazy intervals, it'll do that too. But if you don't need all of that, then if we make it too complex to set up, then people are going to go back to FileMaker Pro, right? So the trick is the trick, I think, that we often sort of challenge ourselves with, is continuing to add on those good ideas, those new modules. Now, keep it designed for the researcher so that they understand it. Do all of the informatics stuff right, of course, but make sure that first and foremost we're keeping our researchers in mind. And then, again, kind of going back to that. Maybe a bad time of year to be talking about this platform, but thinking about it like TurboTax. TurboTax, if you don't need Schedule C, then it asks a few questions and you don't get Schedule C. So REDCap, we try to sort of build to that same framework where we ask a few questions and then just kind of tack on the complexity as needed. One of the questions that came up about the third one of these exercises was, it's great, can I use it for my basic science studies? And that was kind of an aha moment for me that, why not? The REDCap, this is a database, this is software. It really doesn't know or care whether a line of data is about a person or a mouse or a test tube. So from that, we really kind of tried to keep the platform generalizable. And I've been criticized a lot, by folks who say, why don't you just make it, the absolute perfect, phase 3 clinical trial system, or why don't you sort of pick this up and just get down to building the most perfect CTMS system we can imagine. And the reason is that, I like all of those use cases and I like all of those platforms, but if we really just focused in on one of those areas, we'd kind of leave behind a lot of folks that we want to support, and also we'd sort of lose the richness of the diversity of use cases coming in. So, but the answer was sure. You can use it for anything that you want, and we found now that you give smart people access to general solid tools, and they do things all the time that just sort of amaze us in terms of what they're using the platform for, including basic research. We're probably seeing our biggest growth now in global health, but I think it's because it's a lightweight technology stack and relatively easy to use. So. It's kind of a fun exercise. Back in 2004, I think I did a well, I'll talk a little bit about the consortium next and the fact that it's not just Vanderbilt users using it anymore. But as part of that, we have some sort of tracking mechanism to be able to tell when people are citing REDCap. So we pull those publications, and it sort of helps us know who's using REDCap and for what across the world. But back maybe a few years ago, maybe in 2014, I was just kind of looking at this, and over a 5-month period, I was going to give a talk somewhere, but over a 5-month period, I was just kind of scanning through some of the articles, and I found that the top one there is a paper that was published about a canine model, disease model. Second one there was a dog bite prevention intervention in emergency rooms. And the third one was evaluation of dogs with trauma. So it was a veterinarian paper. And I thought, well, how cool is that now I get to show this screen, but it just goes to show again that, you put really smart, you put good tools in smart people's hands and they'll do really cool stuff. So this is what REDCap looks at Vanderbilt as of yesterday. So we're up to about 44,000 projects. You can sort of see, sorry about the go-to over here, but you can kind of see that there's a lot of projects that are research, and they kind of cross that spectrum. There's also a lot of operational quality improvement and so forth. This is kind of what a week at Vanderbilt looks like right now. We've probably got about 600 concurrent users in using REDCap, and we do a whole lot of multi-site type studies and coordination. So these are where people are logging into our local system. So the guiding principles and lessons learned here, I think, from REDCap would be, focus on this universal problem. Designing for the user, in this case, the researchers. I can't tell you how many times people have sort of joined the consortium, which we'll talk about next, and told us, here's how we're going to go ahead and just fix that platform of yours from the informatics side. And I always appreciate that. But usually my recommendation would be, why don't you come on in and get used to it, and let's talk about the researcher use cases and so forth, and then we'll kind of talk about the informatics underneath. So designing it first and foremost for the user that you want to help, and that's the researcher. That finding and empowering early adopters, being able to sort of hit those big labs rather than a bunch of small ones incrementally helped. Listen to the end users a lot, and then use that input to evolve. Again, I wish I had coined this phrase, used systems get better. That was one of my mentors, Dan Masis at Vanderbilt, and I use it all the time, but I think it's absolutely true. Manage expectations. So even though I might say, hey, wait till next month and that feature will maybe in REDCap, I always made a point, and still do, to never promise a function that's not in there today. Because every now and then we get into something and we have to kind of roll back. Well, that's more complicated than we thought. I always want people to be happy with the REDCap platform, and I never want them to be mad at me because it won't do this. So the promise is free. Use it for whatever you want. I'm not guaranteeing that it's going to evolve this way, but I'll tell you it might. Leverage that earned trust. It's amazing once we have a good trust relationship with those researchers at Vanderbilt. The next crazy idea that we have around, hey, I think we could do this. It's easy to get those folks on board to help us. Promoting Even at Vanderbilt, we have folks on the on one side of campus that think RedCap is really nothing more than a survey engine. We have another group on another part of campus that think it's nothing more than traditional case report forms. So being able to sort of promote and re-promote on campus has been useful to sort of let people know that it can do more. And then finally, this measure as you go. I have to meet with my boss once a month. And it's always fun to bring to my boss that, here's some metrics and here's why, we should keep investing in this one and keep evolving it. So the next story I'll tell you is about the RedCap consortium. The consortium really started in 2006. I was given this talk at a national meeting and basically describing here's how Vanderbilt's sort of dealing with this whole HIPAA thing, how we think we're going to scale it out and how we think we're going to be okay. And sort of a tagline of that, I must have said something like, if you're interested in collaborating, let me know. This guy from Puerto Rico happened to be at that meeting, and he said, we'd like to collaborate. And my boss sent me up here to this meeting to see what others are doing. So I said, well, you tell your boss that it's going to take me a while to de-Vanderbilt this thing, and I'd be happy. I want to collaborate with you, but you tell your boss that I want 5% of your effort for 3 months. And then we'll make a go of this and kind of experiment with it. And he came back about 2 weeks later and he said, my boss says he'll give you 30% of my effort for 6 months. So I said, okay, you're a lousy bargainer, but yes, I'll take that. But that was really how it started. And his boss happened to be a biostatistician. So all of that export stuff that you saw, that was his job. That first year was, you help me figure out how we're gonna sort of frame these data exports, right? The next year, the same guy and I were presenting at the same meeting, and we had another couple of guys from the Medical College of Wisconsin. Same deal. We want in, so we said, okay, you can get in, but we want you to deal with we want you to put your effort into thinking about abstracting logins, because logins look different at Vanderbilt than at Medical College of Wisconsin and UAB. They did a great job with that. So then, the next year we said, well, let's just proactively engage, invite 10 of our best friends out there. And this took a little bit of arm twisting, because now we were going out and proactively grabbing folks, and they trusted us, and that worked out really well. At some point during that 10, we decided that this extracting effort from people didn't really scale. So we said, because you can't manage a bunch of volunteer programmers that well. That long. So we relaxed you don't have to put effort into this, but there's something that you're going to find along the way, whether it's leading a committee, something where you can contribute. So it's kind of like you're in, but you owe us something later on. It's kind of a Godfather thing, right? So that worked out pretty well, and I'm not going to tell you about the rest of them, but that was really how it was born, and really I think that same volunteer spirit that started, we'll give you the software, we'll give you the support in exchange for you helping us improve it. It really sort of lives today in the consortium. So the consortium as of yesterday was up to 2,346 institutions in 109 countries. We are really missing Antarctica here in terms of getting coverage on the map. So if anybody has collaborators in Antarctica, we'd love to see them. But it's really been a lot of fun, and the model is still, we'll give it away. No cost. You set it up. You own your own data. You support your own researchers, and we've got this consortium that will help with train the trainer and set up advice and all sorts of things. And we've got all kinds of committees that do all kinds of things, and it's really great. One of those great partners is UAB. So over on the right-hand column there, you see sort of the number of users. You have a number of different installations of RedCap, and I think all total I counted about 1,500 partners, 1,500 users at UAB, and for that I say thanks. So one of the questions that I got for a while from my boss was, when is enough enough? It's fun that you're playing around with this collaboration thing and this consortium thing, but why do you care about the 2,320th partner? And the reason is, what we found is, again, it goes back to that volunteer community. So we obviously don't even expect, all of those RedCap partners to seat people on committees and that sort of thing. But what we found is that, and what we kind of promise is, the people that contribute the most, they have the loudest voice in what comes next. And that model kind of works. And contributing most really might mean that you answer a whole lot of posts on our message boards, or it might be that you lead a committee or whatever. But we've really developed some heroes there that are really responsible for a lot of this, success of the platform. This is my favorite picture. It's brand new as of yesterday. This is Bastavir at the University of Washington and his new child there, who I think is two weeks old, and he looks a little bit miffed that he doesn't have the admin password to that RedCap tablet. So the other reason why that next partner is important to us is the use cases. So I mentioned we're doing a lot in global health right now. It would take us a century to collect as many use cases as we've collected by sharing out globally with folks, and that new users bringing use cases that bring innovation, it really rings true. My favorite story here, one of my favorite stories here was I got on an elevator a while back with somebody in my building. The person worked for a pharma company. It's Amy Rock here. You can tell my photoshopping skills are a little subpar. But Amy started talking to me, and she said, hey, she's with a pharma company in town, and she said, hey, we're using that RedCap for a trial, and it's in Denmark, and we got a collaborator out from Poison Control Center in Denver, and he helped us kind of figure out how to set things up, and the way we set it up, it shaved 6 months off that trial. I thought that is so cool, because I never knew this was happening, and we've got a partner in Denmark working with a partner in Denver, to help this pharma company get something out there faster. So I think again, it's just sort of that for me at least, it was sort of a feel-good story about why the consortium itself is valuable. Global health, here's a neat project that I think wouldn't have happened without RedCap in Kenya, where they've used offline tablets to collect data from about 27,000 folks. This one just came to me yesterday. We have a group that's doing a lot of really cool stuff in Guatemala, and you kind of see the things that they're doing over there on the side there. So there's a lot of really smart people using it for a lot of neat things because of the consortium. But the point of all of that is that the true power is not the platform. And it really never has been. It's been the end users and now, I think the consortium itself. So I've got less guiding principles and lessons learned here, but I think the first one would be choose those initial partners carefully. I think really actually a number 0 would be don't collaborate just to be collaborating. I've tried that and it doesn't work. Find something that really is a win-win on both sides and needs to be done. But after that, I think choosing the initial partners carefully, remembering, and every technologist that I know will tell you the same thing, that the informatics or the technology is always the easy part. The relationships, the governance, all of those sorts of things, those are more important to get right early on, and they're going to be very helpful downstream, and without them, you just can't do it. Earn and maintain trust, listen and be diplomatic. This one's been kind of interesting. I like people to be happy, and I like people to like me, and I like people to like my platform. With a lot of users, particularly a lot of consortium users, you get a lot of great ideas, but also you really get some horrible ideas. So being able to be diplomatic enough to say, yeah, that's an interesting idea. Well, that's probably never going to see the light of day. That took me some skills, but we've got a good consortium, and people really get it. I think it slows you down at first. I mean, I can't tell you how many days in those early days of collaboration I went home thinking, good grief, all I did today was solve Puerto Rico's problem, and I needed to be developing this new thing over here. So it really will slow you down at first, these types of projects, and I think you have to anticipate issues and problems. And one of the things I really had to sort of drill into my own psyche, but also into my team, is things are going to go bad every now and then. And when they go bad, I think it's important that the whole team knows that our culture is we own it. And I've had conversations with PIs at other institutions that were having a question about RedCap, where I felt like it's more fair for me to have that conversation than to ask the collaborator out there. Third story, I'll make this one a little bit quicker, but this one goes to research match. So back in 2001, this reminded me last night as I was reviewing these slides how old I am. But back in 2001, you know, we saw at Vanderbilt, I saw this really strange phenomenon. I'd pick up my phone every now and then, and somebody would say, "Hey, I got somebody on." It was an operator. "Hey, I got somebody on the line whose mom saw something on heard something on NPR, and they want, and so I'm sending them to you." And I would say, "Well, why are you sending them to me?" But it was because, you know, somehow that linkage had been made, and I had research in my title, so I would get these things, and I would have to patiently listen and say, "Look, I'm really sorry, I don't know about that study, but I can probably help you find it." So I knew there were a lot of people out there in Vanderbilt, you know, in the Nashville community wanting to participate in trials. And one of the other things I knew was that, you know, every researcher I know was looking for patients. So we had this idea. This is kind of a busy schematic, but we had this kind of idea that if we could build sort of an online registry, then people could volunteer and we could match them to Vanderbilt researchers, and you know, we'd be able to solve that problem. And it worked pretty well. This was early in the days of these, and the IRB had all kinds of questions, and I spent a lot of time learning about the IRB at that point. So we couldn't do everything that we wanted, but it worked pretty well. But one of the things that we found was that, you know, people from California are joining this thing. So why in the world would people in California be joining a Nashville registry? It sort of kind of dawned on us that, you know, this is not a Nashville problem. This is a universal problem that we all have. And so we thought about, well, what about a national model? And that's when we kind of had the idea, and through the CTSA implemented this platform called Research Match. So Research Match is it's a disease neutral, institution neutral tool. It is more or less the model that I just described. People can say, I want to be involved in research, and we have sort of this privacy preserving, you know, enable IRB and privacy guided approach to being able to allow researchers at any participating institution to be able to reach out and connect with these folks. It's free. It's a complementary recruitment service. UAB has other recruitment services that can drill down farther into your EHR records and so forth. So do we at Vanderbilt. But this is sort of a public, you know, group of folks. It's safe, secure, and I mentioned the institution neutral. So screens kind of look like this. If I'm a potential volunteer, I take about 5 minutes and I fill out some information about myself. Demography, as you see here. Medical conditions, and this one's the, you know, really from an informatician standpoint, this is the coolest part because we're able to use some standard terminologies and concept mapping so that the patient can say, I've got a history of heart attack, and the physician can say, hey, I'm looking for people with MI. So we're doing all of that stuff right, we think. You can do the same thing with medications. And then there's another screen I forgot to include that says, how far are you willing to travel? So with that, you know, we're able to sort of compute, you know, how far are you away from Vanderbilt or UAB or any of the other partners, and use that. So as a researcher logs in, there's a whole process in the trust model with institutions that are partners, and I'll skip all of that. But I will say that, you know, the researcher, once they're in and they've got an IRB approved study, there's a pretty simple tool that allows you to kind of filter down and find from that 100,000 plus set of folks, these are the people that I think would be most useful to participate in this study or trial. Once you find that, there's a way to review the records in a de-identified fashion, stick in an IRB approved language, and then the volunteer gets a message that basically says Vanderbilt or UAB researchers are doing this type of research, and if you're interested, click here. We do have a mechanism that if you're using RedCap at your institution and you wanted to put a pre-screening survey, they can also, you know, when they say yes, it can also direct them to your servers at UAB to fill out that pre-screening survey. After that, you know, it's more or less the connection is made, and now you know, the education and the onboarding works just about like any other trial or study. This one works as well. You know, we've sorry, I thought I had a screen here that showed a map of where people were, but you know, we've got volunteers from all over the country. As Adrian mentioned earlier, you know, I'm a little bit embarrassed that Ohio State is a better research match partner than Vanderbilt, where we invent the thing. But you know, we've got a lot of good institutions that are using it for good reasons. So lessons learned on that one would be make partners out of those regulatory groups early and often. The other two I've already mentioned, so I won't mention again. And then be opportunistic. Use every asset that you've got. And I mentioned some of the terminologies and the standards that we're able to deploy here, but also recognizing at some point that the way you get volunteers is you go to the advocacy groups and you figure out ways that you can help them help their constituents. So it's 9:52. I can't remember. I've got to stop at 10. Is that right? Okay. So in the next 8 minutes, I just want to go over just a few of the things that we've got going on right now. They're coming soon. These are things that I always ask when I go to another institution. You know, whoever I'm talking to, I usually say, "What are you passionate about right now?" So these would be my 3 passion projects. One is tying RedCap to Epic, we're not yet an Epic shop. We've been sort of a homegrown, build your own EHR system at Vanderbilt for a while, and that's really been great for a lot of things. As an informatician, it's a great playground. But come November, we're going to be an Epic shop. So as part of that, we've been working a lot with the Epic folks and trying to figure out ways that we can put hooks into the workflow of the hyperspace, you know, the clinician view of the EHR, in my chart, you know, the patient portal, and also sort of thinking about maybe cutting out the middleman in this methodology that we developed a few years ago that allows us to sort of hook RedCap up to research data warehouses for data flow, for the mapping of records in RedCap, mapping of records in the EHR system, and data flow for registries and longitudinal studies. I can say that we've had probably 2 to 3 months of just banging our head against the wall, trying to figure out, you know, how we're going to do some of these connections and interoperable pieces. Just 2 weeks ago, we had what I think is our breakthrough, and we've been able to do some really cool proof of concept work. Again, we're not live, so I can't put this into production, but we have done some really cool proof of concept work that make me believe that we can probably pull these off a lot faster than we thought we would, and it's really enabling some new thinking about this intersection between the EHR system and the research systems. One of the really nice things, without boring you with a lot of standards discussion, is that I think the way we're doing this should be able to be implemented in a relatively easy fashion at other Epic installations. And I hope, because we're using sort of standardized transmission protocols, that we will be able to, that this will also be work that would inform maybe doing the same sorts of things in Cerner. So that's one of my passion areas, and it's one of the things that we've wanted to do for a long time, but not being in the Epic club, or not being in the store-bought EHR club, you know, we really had some limitations on what we could do there. So another one that we're working on now, that you know, as Jim mentioned, I've been being part of this Recruitment Innovation Center for the Trial Innovation Network with the CTSAs. I'm spending a lot of my waking hours thinking about recruitment these days. And you know, as we think about, you know, what do we have in Research Match? It works pretty well, but if I really think about this guy, the volunteer, he's coming to a site like this for a reason. He wants to find trials. He wants to participate in research. And if you note the statistics of yesterday, at least, you know, I've got 536 studies that you know are currently using Research Match. There's a lot more studies than that in the world, or in the country even today, that are recruiting. You know, we have sort of a new platform, or a new sub-platform that we're launching out, called Trials Today. And basically from this, we can pull from clinicaltrials.gov massage data and present it back to the volunteers in an interesting way. But we've got 19,000 recruiting projects across the US. And so, you know, one thought of this would be, yeah, but you know, we're the CTSA, or yeah, we're Research Match, and we're these institutions. And so you know, the part of me has had to sort of deal with this. But you know, going back to that principle of who are you designing this for? This guy doesn't care about the CTSA. This guy doesn't care about Research Match. You know, this guy really just wants to participate in studies and trials. And so it's trying to figure out, you know, a way that we can help more. If you care enough to be at a site like Research Match, that's what we're all about here. So we've done some preliminary work. We've got about a year's worth of data, being able to sort of present the right trial to the right person based on what they're telling us about themselves. And as part of that, we think we really got a model now that sort of leverages that whole research match ecosystem, and we can sort of do both. We can sort of treat these studies preferentially, if you will, while still presenting all other studies and trials, and maybe even helping with that initial contact. But that prioritization of projects, you can imagine that if we're going to present to you any project, first we might bubble up to the top of the list the ones that are research match studies. They're already registered in research match. Next, if UAB is a partner and University of somewhere else isn't, it might be polite to say, well, we'll prioritize the ones, all things being equal, we'll put the UAB ones at the top of the list, and so forth. So we're thinking some of that through. But one thing that's kind of interesting is that while we're thinking about that, the data that we need to decide whether a study is a Vanderbilt study or a UAB study, it's quite useful for us. It's necessary in that prioritization, but as a spin-off of that, we decided, hey, we're not going to build yet one more Vanderbilt-specific trials registry. We're actually just going to sort of rebrand, reskin, apply some of these rules, and we, again, we'll just save ourselves time, and we'll be able to sort of customize and use our own work for our own, our Vanderbilt local piece. What we found is that a lot of institutions are thinking the same way, and so we've got some really early collaborative partnerships with some of the institutions that you see here and others. And thanks to Jason Nichols, we've been thinking about this in a UAB view as well. I should say before you get excited that this is not live. It is password protected, and so even if your lawyers are here, I promise we're not doing anything that we shouldn't here. But it's really kind of an interesting way to get the recruitment folks banded together and sort of thinking about, how could we work together to maybe work globally as well as locally at our institution. So I'm hoping that will continue. And then the final thing I'll mention is we've been working for some time looking at patient-reported outcomes. So being able to sort of collect data directly from the patient. And RedCap for a long time has had a lot of survey capacity, but it's sort of one-off. You'll get a notification by text or email, and it's time to take this survey. That's a lot different than sort of an application that my mom would be happy to walk around with every day. So we've been developing, and we're just deployed I think 2 weeks ago in the App Store, this platform called MyCap. And it's really the exact same principle that we talked about for RedCap. Applications are expensive. They're expensive to develop one-off. So we've developed this method where we develop one app, we change in and out the metadata to make it study specific. The authoring platform here is basically our RedCap plugin, and the data come to live in RedCap, but it really is a native app, and it looks like you would expect a native app to look like. In addition to surveys and that sort of thing, which it does really well, it'll also do the active tasks. So if you wanted the research kit task ingested for a 6-minute walk, or finger tapping, or some sort of cognitive task, it'll do those well. So we're about to launch these out. This is not live for everyone, but we're gonna pull it out in the next couple of weeks. We're gonna start building it out for some N of 1 studies and a couple of pragmatic studies at Vanderbilt, and then we hope to have this launched out by August to the consortium. But if we have people that are interested in this, just let me know. That is all, and I think I'm right out of time. So thanks for your attention.
Okay, that was terrific. Questions for Dr. Harris?
Thank you very much, Dr. Harris. I don't know if we have time, but I have 3 questions. When you started talking about describing informatics to your mother, you talked about disease-neutral ways of building platforms or methods. So when you're initiating these kind of projects, how do you find funding, especially when it's disease neutral? The second one is, you said that you're going from homegrown EHR to Epic. What are some of the decision-making criteria for that? I'm asking this generically, not necessarily for an EHR, but for any project when you're deciding to build in-home versus purchase from a vendor. And a third one that you're talking about interoperability between Epic and RedCap, and you said that you had a breakthrough. Can you elaborate on that a little bit? Does it have anything to do with the Smart on Fire platform?
So I'll answer them in different order, and I think there's a break afterwards, so we can talk a little bit about this during the break as well. The third one is yes, it is leveraging the Smart on Fire methods. The first one about funding and so forth. You remember the title is Build Small. Think big, build small, and evolve. So the trick, I think, is usually for funding as well as, is this really a good idea? To build it as small as you can. One of the things that people are used to hearing from me on a regular basis is, if we could do, this is a great grandiose idea that you have, Dr. Jones. If we could do something next Tuesday that would change your life, what would it be? And why don't we just start right there? And if it does bear fruit, then we'll build on some more. If it doesn't, then we haven't lost much. Usually it doesn't cost much to build that first piece, particularly if we're just going to be leveraging something we already have, like RedCap. But if it hits and it does change the world, then usually the funding can be found. The second one I'm going to defer to the break, and that is, what kind of considerations go into building and buying and either small systems or big systems. But let's talk about that during the break.